you. Good afternoon. Is everybody still awake? So I've got jet lag, so that's my excuse. But I'm happy to be here in Bangalore. I never thought I'd have the day when I was happy to be in Bangalore because it was cooler and wetter than Amsterdam at the moment. We're in the middle of a drought over there, so it's quite spectacular heat. I think it's 39 degrees last week. 104, 105 in old money. But happy to be here and share some insights into what we mean when we talk about designing healthcare in Philips. Now, I'm very fortunate. I've got a great job. I get to play with all of these incredible technologies. I work with some of the most talented scientists and technologists in the world, including 3,000 of them sitting right here in Bangalore, where I also have a design team where there's more than 50 designers who are not only practicing good design, but design thinking as well. And so through this presentation this afternoon, I'm going to give you a little bit of insight into the role that design is playing in the transformation of Philips and the impact that we believe technology can have in the way we create our products and solutions. So, one of the key things, I think we've touched on this a few times during this morning as well, technology alone will not change healthcare. We have to respect and understand the role of the human in this process. Now, that's about the patient, of course. The patient needs to be very much at the center of everything we're developing. But equally, if we don't have the clinicians, the nursing staff, along with us in this, if they feel that the technology is getting in between them and the patient, then that's going to create an issue as well. So we don't want to end up with a situation where we're creating boundaries through the use of technology. Now, we believe strongly that the way around this is by co-creating with clinicians, with caregivers, and with patients and their families, the informal caregivers as well. So using a process of design thinking, which we brand ourselves as co-create, we get many of the stakeholders around the table as we possibly can. And I'll talk a little bit more detail about that as well. This slide's not moving on this side, by the way. So technology is emerging at an ever-increasing rate. We now see artificial intelligence coming in, with the Internet of Things, the Internet of Medical Devices. We've got new software running on, over here we can see genomics and digital pathology, and new ways of reading images, which you can see over on the far end there as well. We're also incredibly now able to build and hack products. Over there on the bottom, you see actually, I've got a pointer here, haven't I? This is a product our designers and technologists hacked. It's a connected baby bottle. Why would anybody connect a baby bottle? Well, we're one of the biggest vendors of baby bottles and infant feeding products in the world. But when we challenged ourselves, did we know anything really about the way mothers were feeding their children and how to help them get a better feeding cycle? We didn't. So we hacked a product with some Raspberry Pi, created some dashboards, put these products out and started to collect data. And through the data, we're able to innovate and start to think about new ways of designing the product and developing new care pathways as well that would result in better quality experiences. Now, the experience that came out of that particular exercise was that mothers actually got a better night's sleep because the feeding was more productive, and we could coach them through an app in terms of how to give the best feed based on their own personal contextual data. So not a generic piece of data, but their own personal data. So these are the kind of experiments we're increasingly running. Also, as we look at this, I'll come on later to the role of virtual reality, augmented reality, and blended reality. Because what we see more and more, the reason I put this slide up is that all of these new and emerging technologies start to come at once and they start to come together. And it's when we start to think holistically about this as a system that it opens up new opportunities for us. So it's the Internet of Medical Devices, it's the role of big data, it's the insights we can derive through the use of artificial intelligence, new ways of interfacing with all of this data and with these products through haptic, gestural, voice control and things like that. It's a fantastic time to be a designer when you start to think about the opportunities that we've now got. Now at Philips, we've got a number of ways of looking at the opportunity. Daniel touched on some of this morning, so I won't go too detailed on it. But there's a huge challenge facing healthcare globally. A number of presenters have talked about it specifically in the context of India with access to care being very spotty. So if you're fortunate to live in a built-up urban area in a city, you've probably got reasonable access. But once you go a little bit further out into the country, it becomes increasingly difficult. But again, technology can help us there. And the challenges are the same wherever we go around hypertension, diabetes, respiratory care diseases, aging populations. You know, these themes keep coming back. And what we know for sure is that if we don't start using technology to address these, the cost of care is just going to be prohibitively high. So these are, out of all of the trends that we can map, monitor, and pay attention to, these are the ones that at Philips we're prioritizing. So global resource constraints, aging populations, a positive, increasing consumer engagement. I think Prasad talked about his wife Googling symptoms. I mean, that's something that we see all the time. As a practicing physician, many of you will have probably experienced people coming into your waiting room with a pile of printouts or already challenging you on what they believe is wrong with them. So there's a good side of consumer engagement if you're going to catch disease earlier, but also the negative side as well. And we have to find a way of curating those experiences. And digitization, of course, this is the reason we're here today, is a huge opportunity. I think Daniel also talked about this as well. This is our way, this is the Philips strategy, in essence, on a page. So rather than focusing on treating sick people, and thank you for using Franz's quotes a number of times, so I'll make sure he's aware of that, we believe strongly that we've got to move away from sick care and treating sickness into treating holistically. Thinking about preventative medicine, helping people live a healthy life, and this is where our consumer portfolio continues to play a key role, doing early detection, diagnostics, treatment, and then getting people back into their home and out of the hospital system as soon as possible. We've got a cloud which connects all of this, whether it's consumer-connected propositions like a connected toothbrush in the home, or the MRI machines and CT machines which are firing data into our cloud, or the patient monitors where we have around 350 million patients every day streaming data into that cloud. And the imaging data we sit on, by the way, is 23 to 24 petabytes, somewhere in that region, of imaging data. So this is really substantial data that we've got here. And we've got to mine that. So we've got our insights platform, our artificial intelligence platform that we've developed in order to mine that data. All of that is done with the aim of moving towards addressing the quadruple aim. So it's about improving the patient experience and getting better outcomes, but at the same time, lowering the cost and driving efficiency in order to make this sustainable and scalable. But if we don't take care of the improved staff satisfaction, all of this will just be a fantasy. We know in many developed markets, particularly in the US, quite often we know the intimate relationship that should exist between a clinician and a patient, there's a barrier between them. And that barrier is often the EMR, because the clinicians are slaves to the input of data into the EMR, and that's taking them away from actually even eye contact with the patient, which is not a great user experience. So those are some of the challenges, I think, where design can begin to help. So part of my role is to not just get tied up in the here and now of technology and problems and issues, but to look over the horizon, envision a new, bright, shiny future. But here lies a bit of a problem. When we start to get into the world of concept cars and fantasies, then how many of those are actually going to happen? How do we ensure that those future visions become reality? Now, back in the 1960s, Philips commissioned a very famous industrial designer called Sid Mead. He worked on movies like Tron and Star Trek and things like that. And he envisioned what the 1980s This is a 1980s living room would look like back in the 1960s. Now, some of it may not have happened, but really I don't think many of us lived in living rooms like this. But what motivates me more than anything else is that this is a quote from our founder, Anton Phillips, that he was always challenging people to say, think differently, think outside the box. And he's found that fantasy could be one of the key factors in a successful outcome. So with that spirit in mind, but also with equally the knowledge that we have to keep whilst we've got our heads in the cloud, feet on the ground as well, we started to look at some key issues around healthcare and the way it's delivered today. Now, one of the first ones we looked at with this in mind was looking at premature birth and particularly around the neonatal intensive care unit. Now, we've had a lot of success here. Over the course of maybe 20 years, the survival rate has increased dramatically. We're now looking for about a 27-week neonate, a 1 kilogram baby, that there's a 95% survival rate. But at what cost? What we hadn't understood when we looked at this was we were treating, again, the sickness, and the sickness in this case was the fact that the baby was born prematurely, but we weren't thinking about holistic care. And, you know, believe it or not, even 10 years ago, not many people believed the neonate could actually feel pain. And what we found through the research we were doing here was that overstimulation, and this is a very good NICU that you see here, around the corner from us in Eindhoven in the Netherlands. It's got access to daylight, the parents are actually there, they're able to make skin contact in the fishbowl here. But you notice, to get that baby out of there can take the nurse 40 minutes to disentangle the baby so they can get skin-to-skin contact and do the kangaroo care. So it's not exactly a patient-centric view of the world. So what we said was, let's think about this, let's look at all the insights we can gather and create a vision for the future. So this is what we put together. This is our concept car for the neonatal intensive care unit of the future. And on here you see dashboards where we pull all of the data together around the patient monitoring, the baby monitoring. You'll see there's a cocoon there that the baby is in. The light is on at the moment because there's a clinician in the room. I can tell there's a clinician in the room because this is a clinical dashboard that's showing. If there was a parent in the room, this would be an entirely different dashboard presented in a patient-friendly way. So the room is contextually aware to the occupants and to the status of the child at that given moment. So it's catering and adapting to the needs. So what we're looking at here, and this is a notion I really want to push, is move away from artificial intelligence and move towards ambient intelligence. So ambient intelligence within the context of a hospital has a huge potential to make a big impact on the way we deliver care. So this is what we're looking at now, is trying to embed intelligence sensors around the hospital. So the lighting, as I open this, if the parents were in place, would dim, and it would adjust the sound, the noise to the baby's needs. So it's all around patient-centric care. So that was the vision of the future, and I pulled in 2,500 key opinion leaders, neonatologists, intensivists, experts in PICUs and NICUs, to come in and run sessions with them, to have them kick the tires of our concept car, tell us what was good, tell us what was bad, and build on the concept that we got here. Through that, we're able to then start to iterate and start to look at how we could deliver something like this even today. So one leading university hospital in the US, immediately they'd gone away from that session, commissioned us to design the next generation NICU. So this is a hybrid NICU and PICU that we put together, where many of the concepts are embedded. It's not as far out, this is delivered today, but it's already addressing many of the needs that they had in place. But as we started to think about this room with the ambient intelligence within it, we put that in the context of an end-to-end flow. And we started to thinking about fertility, pregnancy, parenting, tracking and monitoring how that birth happened, looking at the data that led to the premature birth. Was it preventable? Were there early indicators and warning signs that could have helped that? Looking at the context of how care was delivered, and looking at what data would exist. Now, of course, as few people have pointed out, when you start to look at data on that level, it's all in silos. It doesn't connect. The EMR is in one silo, the patient records over there, the medical records, the clinical data being streamed out of the NICU, probably in a separate one, the imaging data, everything. So how do we bring that all together? So that was one of the challenges we looked at. What we also looked at was the role of the parents, the informal caregivers, the clinicians, and the intensivists as well in there, and started to map out pain points across that. And this is kind of a map that we use in all of the work we do now. Multi-level stakeholder mapping allows us to understand the pain points of not only the patient, the nurses, the primary physicians, but also maybe the CIO of the hospital, who's now got the burden of trying to integrate all of this data and have disparate systems that now need to talk together. If we don't empathize and understand his problem, then we'll have a challenge and an issue on how to bring all of this to fruition. So the role of big data really starts to become important here. This is the point I was making about multiple sources of data. Some of it will be within the Philips ecosystem, some of it won't be. And that's why as we build our cloud system, we think about how do we integrate third-party data. The fact that many of you in the room will be wearing third-party, well, for us, third-party wrist-based devices. It could be Fitbit, Apple, Samsung, Huawei, it doesn't really matter. You'll be carrying your personal data on your phones in different ways. If we don't have a system that could ingest that data, then we're never going to be able to scale this practice as well. So again, I think somebody talked about democratizing data. I think that's an important part of making data work for healthcare going forwards as well. So we have APIs and SDKs to allow people to develop on these platforms. From the insights we were deriving from all of the work we've just done on the NICU, what we were able to do is then start to look at an insight-driven, so driven by data, but put together a holistic developmental care pathway, where it's not only about treating the sickness, the particular ailments of the premature child, but thinking about all aspects of how do I make a healthy child and set the parents up for success. Because when you've had a baby in a NICU for maybe 6 to 10 weeks, or even longer in some cases, it's pretty intimidating to lift that child out and go home with this child now. So how can we connect back to them, help train them along the journey, and then also continue to monitor them, coach them, and advise them once they've gone home as well? So this is a care pathway that we now put out there, and we teach people and use it as an education tool. And of course, that made us then look at the rest of our portfolio, and we started to think about how would we take that concept from the NICU into intensive care. And so we redesigned the care pathways and started to look at intensive care in a different way as well. And really it's about these two kind of macro headings, about curing the illnesses or the particular ailments, but equally recognizing the care that we need as well. For instance, adults sitting or spending any extended period of time in an ICU, we know delirium becomes a factor. You become sleep deprived, alarms going off all the time, no natural light, and your circadian rhythm goes all to pot. So what can we do about that? So we started to think about how we integrate, again, all of these different systems and apply that in the context now of an ICU. So that's not just a pretty picture projected on the roof of a cloud. It's actually got the right frequency of blue lights in there to suppress melatonin, produce serotonin, and get your circadian rhythm going. So even as you're lying there in your most fragile state, we're helping to heal you as you go through this. And the data that's streaming out of you is actually fueling that as well. So you're connecting the patient into the ambience of the room. So as I said, I'm beginning increasingly to hate the term artificial intelligence. I think we should be starting to look at other terms for this, for AI, like adaptive intelligence, augmented intelligence. Because I think really what the opportunity that exists here with this data is, with the use of adaptive intelligence or augmented intelligence, is to give you as clinicians superpowers. So as you're there dealing with a patient at point of care, make this data available to you so that you can have the world's knowledge at your fingertips and make the most informed decisions you can, but personalizing it towards that particular patient as well. And this is where the concept of a digital twin comes into play as well. So it's all very well to have data around cohorts of patients similar to this, but I want to personalize it and tailor my treatment pathways towards that individual. And that's where now pathology and genomics and profiles, and feed that together holistically so that this truly is a digital twin. It will make me, allow me to give more informed decisions as well. So a lot of connectivity around the back of this to make that work. And this isn't just fantasies for the future. Many of you are radiologists in the room. You'll know we have a product already, Illumio, which is a radiology software that is contextually aware, so it knows the kind of image that you're looking at. It's doing anatomical recognition. It's pulling data from the background and making it available to you to aid you in clinical diagnostic support at the moment you need it as you're doing that diagnostics. Now, that raises huge challenges for us when we're thinking about user experience design. Because in the past, user experience design, if any of you are software developers, you would know, you basically write out a system of architectural flows, you look at information hierarchy, and then you present the data in the most meaningful way. Now, with artificial intelligence, you can have data popping up in context. So we've really got to think differently about the whole way in which we design user interfaces going forwards. Now, the good news is we don't have to do it alone. And this is where design thinking can combine with thinking designers to create this co-creation of new software platforms. And this is our process. It's developed with Stanford D School, SAP, Hapner Institute, some of the best thinking in the world we've benchmarked this against. It is our Philips proprietary way of doing design thinking, but it follows pretty much the logic you'll find in any design thinking manual as well. It's about discovery, framing in order to derive insights, ideating on those insights, then building minimum viable prototypes, and then iterating quickly through that. It's also about understanding people and bringing people along. We heard earlier that the healthcare industry is not always open to change, can be quite resistive to change. And we were told quite often that, look, that's a great pathway, this is a great new way of doing things, but the nursing staff will not accept it. So what we said was, well, why don't we bring the nursing staff in on the development project? And by co-creating with them, we're able to actually get this through. So it's part of a change management process as well. And we do this through what we call the Health Suite Labs, and we have the facility to run these right here in Bangalore. We're doing that with a number of customers here. As I said, I've got 50 designers sitting here who can co-create with the local market, with local providers, and also partners, IT partners perhaps, to develop some of these propositions. Now, the team here is working not only in India, but globally. This is a project that we did maybe 2 years ago called Mobile Obstetrics Monitoring. So we were approached by the government of Indonesia, who had a very, very high infant mortality rate. And they asked us what we could do about it. Now, many of those problems we've touched upon here when we talk about the India market as well, that you've got people who have not got direct access to healthcare providers, to skilled healthcare providers. You've got poor literacy in some areas of the market there, and semi-skilled caregivers. So we sent the team from India down to Indonesia. They went out to the remotest regions of Indonesia, to the islands, and spread across the whole area to understand how people were delivering care in those areas. We actually then prototyped an application that would run on very simple phones in order for them to deliver and guide them in the way they were delivering care. We took 1,000 women into the first trial. In that first trial of 1,000 women, we identified more than 60 at-risk pregnancies that were already able to then escalate and help avoid those becoming an issue. So that's when we talk about design with meaning, or working for a brand with meaning, a company with meaning, that's where you start to get impact. We also worked, of course, with the caregivers back in the center of this, in the hospital itself, to make sure they understood what we were doing and that they would be receptive and help us with this. So from that, though, whilst we understood how to deliver basic care, we also said, wouldn't it be great if we could have ultrasound imaging so we wouldn't have to have people traveling hundreds of miles in some case to get a simple ultrasound. So this is where the idea was first floated around mobile ultrasound. So ultrasound that's based in the cloud but can be delivered through a transponder, and in this case an Android device at point of care where it counts. So rather than talking about hundreds of thousands of dollars worth of equipment, which often would stand idle because there wasn't a power supply available or an operator available, now we can put it into the hands of semi-skilled workers in the field to do imaging remotely. And then using artificial intelligence and connectivity back to the care center, guide them in acquiring the images, analyzing the images, and processing it, and giving them guidance at point of care. I didn't have an image of mobile obstetrics here, but this is some of the anatomical recognition that goes on in the processing in the cloud, which would allow then a semi-skilled user to understand exactly what they're looking at, and for the remote radiologist to give input in how to deliver the care and what the most appropriate care would be. So that's how AI is now augmenting that ultrasound delivery. But we're also using it in planning of hospitals and healthcare systems. One of the speakers this morning, I think in the panel, talked about it's no use just coming with faster pieces of equipment, 16-slice CT machines and higher output MRI machines, if the biggest problem is really the waiting room and how quickly the patient can get dressed and undressed. So what we're able to do now, and the animation is not working here, but this is an architectural model that we build. We place the machines in there, and then these two little characters should be running around. And we can actually evaluate how long it would take them to get through in there. And then we can look at, do we want a faster machine? Do we want more machines? Or do we actually, all we need is 3 more changing rooms? And by putting 3 more changing rooms in there, we can decrease the cycle time, increase the throughput, without having to invest in huge pieces of technology. Daniel's probably glowering at me right now because I've just stopped him selling another MR machine. But what this does is drive efficiency. And this is a way that AI can start to help us there. So, we design medical equipment, we design toothbrushes, baby bottles, but I bet not many of you knew we're also designing hospitals. Now, it started out designing, literally, the imaging room and making a better patient experience around the MR or CT. But what we quickly realized was that you have to think holistically about the entire hospital, the entire care pathway. So here we now bring together operational efficiency with clinical excellence, technology innovation, and patient experience. And we have, part of my other job, I have 2 jobs at Philips. One is Chief Design Officer. The other, I run a business unit called Healthcare Transformation Services, which is a team of consultants, and we have a team sitting in Delhi, servicing the India market, and they can come in and do an analysis of the clinical needs of the population, come and design, help co-create your clinical service lines, and then design the appropriate healthcare facility to service that population. Now that takes a bit of an army of capabilities and competencies to do that, from hospital planning consultants through to our design thinkers, architects, program managers. And then on the other side, you have the clinicians, which are you guys, the radiologists, the nurses, and the CIOs and the CXOs of the hospitals that we team up with then to deliver these environments. We do a lot of shadowing inside existing facilities. We go and do contextual interviews. We'll play the role of a patient ourselves so that we design something that's not copy-paste from maybe a big, flashy American university hospital, but is appropriate to suit your needs, your context, and your population requirements. And you only get that by immersing yourself in the experience. And that's why I have a team here, and I don't pull all my designers and consultants in Amsterdam, because we need to be in the context, we need to understand local relevancy. We also use the team here when we're looking at projects around the world. So this is some investigation we did for a new hospital in Xiamen, a cardiovascular hospital. You see here getting intimate with staff and patients, understanding again the clinical workflow, all in Chinese, so I won't ask you to understand that, but we see all of the opportunities, the care pathway, and then pain points that we start to map along the bottom here. And then we take those pain points, we articulate them as opportunities, and then start creating the design over here of that new facility. And this particular hospital will open at the end of this year. It's just finished the topping out right now, so we're building all of the interiors on this one at the moment. This has also led us to, and this is a big one of those bigger university hospitals, this is Westchester Medical Center in Hudson Valley in New York, where we've actually gone through here and designed an entire facility, but also the ecosystem with connected primary care, and then looked at how we do the enterprise planning around that hospital as well. So here in India, our HTS, Healthcare Transformation Services Infrastructure team, sorry, I didn't realize there was animation on this one. We can do everything, as I said, from strategic advisory through to operational consultancy, looking at how you drive efficiency and productivity in the hospital, into then designing and building the system as well. And these are just a few of the projects we've done in Bangladesh and then in various parts of India. I think we've got about 7 projects running currently, more than 2,000 beds total at the moment of hospitals we're designing right now. We also use artificial intelligence here as well, and VR, augmented reality and AI. And you'll see here designing the layout of a cath lab. So we also have the hospital as a complete BIM model, architectural 3-dimensional model, so we can have the cardiologist walk through the patient experience, understand the layout, understand the flow, and make adjustments still while it's on screen before we actually start to build anything here. So these concepts that we start to put together then based on this, I mean, this was a concept drawing you see here, and this was with a proton therapy suite, proton therapy on this one. And you can see how we're looking at humanizing a very extreme piece of equipment here with materials that are appropriate to the context of use. So yes, it's got a little bit of a clinical feel, but by the use of woods and honey-colored materials in here, we also humanize the experience for the patient in a highly stressful environment. And that's leading us now to designing more and more. This is some work we're doing also with the team at the moment in the Middle East, in Saudi Arabia, around, again, a huge hospital. It's got to be contextually relevant, so you'll see a lot of the local cues and signatures around colors, material, and finishes in that context as well. So really, Philips' mission right now is to help 3 billion people a year by 2025. That's the journey that we're on. But we know we can't do that alone. We know that we need to partner with patients, with caregivers, with hospitals, insurers, and with yourselves as well, including third-party device manufacturers and data players as well. And it's only by getting people to work together, to work in this combined way, that we'll really start to address these 3 billion people. So that was my presentation for today. Thank you. So I think there was a few minutes for questions, yeah.
This is by far the most visually appealing healthcare presentation I've seen in quite some time. Carefully thought out, extremely calibrated, and terribly detailed, excruciating detail. Wish you could make it available online, that'll be great, at least aspects of it. I couldn't help but ask your opinion on, this is not so serious matter, Charlie Brooker's Netflix series, Black Black Mirror and how much of that is possible in the, let's say, another 10, 20 years, in your view, if you're familiar with it?
I'm not. Sorry, what was the...
The Netflix series Black Mirror by Charlie Brooker.
Okay. No, I'm sorry, not seen that one, no.
Okay.
Was it a vision of healthcare? Or?
Aspects of healthcare are interspersed quite a bit in that series.
Yeah. There was one in the US I did see, but I think it's been discontinued by CBS, which was looking at many of the things we're talking about, but then bringing them to life. I think there's a lot more possibility to use technology today, and I think it's up to us to make the space to bring it in and adopt it. But I think it has to be done in this co-creation way. If we just keep coming as a device manufacturer with new technology and pushing it and selling it, then there will be resistance. I think we have to find ways of showing how it impacts outcomes and how it improves efficiency and productivity. If we can do that, then we'll get a much quicker rate of adoption as well.
Hello.
Sorry.
I'm Dr. Srinath Manikante. I'm head of the neonatal services at Fortis Laughlin Hospital. I'm a neonatologist by profession. I worked in UK for 11 years. And now I'm heading a human milk bank in Bengaluru, which is one of the first public human milk banks, which serves premature babies all across Bengaluru.
Okay.
It's quite appealing. The presentation is fantastic and quite promising how AI can help neonatal care, complete care. However, after coming back to India, the challenges in India is home to world's biggest population of premature births.
Right.
3.5 million babies every year. Unfortunately, most of them do not have access to neonatal care.
Yeah.
The need of the hour in neonatal care is cost-effective neonatal care. Unfortunately, many of these incubators, CPAP machines, and high-flow nasal cannulas or ventilators, they cost the same as in West as in India.
Yeah.
Because of this, many of these premature babies are deprived of neonatal care, basic neonatal care.
Yeah.
Is there anything can be done to bring up cost-effective NICU?
Well, I think it starts by doing exactly what you're doing, making us aware of the challenge that you have. For instance, the Indonesia discussion, first of all, we would have started to say, okay, if we want to get a lower cost ultrasound, how do we strip out parts? How do we pare down the device we've got and lower the cost? And in doing so, run a high risk, we'd lower the quality and things like that. Actually, by having clear articulation of the problem as we saw it, saying, well, it doesn't matter if we made a lower cost, lightweight ultrasound, they wouldn't have the power, they wouldn't have the people. We had to reframe the problem, and in reframing the problem, that's where we came up with the mobile obstetrics monitoring, with the Lumify device. So if we start to look at your challenge, how can I provide neonatal care at the lowest possible cost, make it accessible in a market like this? And if it works here, it's probably also relevant in Indonesia, and we talked about this morning, maybe Central America and other markets. Then there's maybe a nice business opportunity as well for us. So I think that's where these co-create sessions, maybe Daniel, Prasad, these are the two local guys, we can pick up these as opportunities and see what we could do to provide technology and design thinking help to see if we can find solutions there.
Point of care ultrasound using Android mobiles is amazing innovation.
Yeah.
It's fantastic. Hopefully, we can come up with some innovations for neonatology where majority of the neonates actually need it in India.
No, absolutely. We'd love to do that. Yeah.
Thank you.
Thank you. Thank you.
Hello, Sean.
Hey.
Thanks for your presentation. It's great to see all the advanced concepts. I work for Philips myself.
Okay.
I have a question on the beginning of the sort of continuum of care from Philips, which is on prevention. And a large part of the prevention is actually behavioral change.
Yes.
I know we are good at fixing everything but our own behaviors as humans. So are there any concepts that exist or anything that exists that would help change behaviors and lifestyles of people, and how can Philips assist in that?
I think, yeah, so it comes back to your presentation as well, when you talked about, well, why would people smoke or chew tobacco when they know the consequences? So it's very easy to kind of say that when you're sitting in your ivory tower in a nice city, surrounded by nice environments. But when you go and do contextual interviews, when you understand the motivation for why they're acting in this way, then you begin to understand. So it was about the factory workers trying to get through their shift without having to break for eating, the access to drinking water, things like that. So there are many factors which contribute to, let's say, obesity and diabetes and sedentary lifestyles. And we've got to look holistically at that as a whole if we're going to modify behavior. And that can't be just Philips. So we have to team up with those device makers, whether it's Apple, Fitbit, Samsung, Garmin, and everybody else. And then maybe what we can do is bring some of our insights into coaching programs that can live on somebody else's application, but nevertheless help us lower the rate of disease. So I think it's by brokering and teaming up and finding alliances together that will start to address these prevention opportunities as well.
Hi, Sean. This is...
Difficult to see up here.
This is Raghu.
Yeah.
Sean, this is Raghu. So my question was very specific to your integrated healthcare design, which you mentioned. So I saw a lot of entities there, but there was one thing that was missing, which I felt was the risk that is involved, especially with the number of devices that come into play in the healthcare spectrum. The reason why I'm asking this question is when we go and speak to customers, the first question that they ask is, oh, okay, so how do you manage risk? So how do you manage this regulation? How do you manage this? So there is, instead of going into the actual design aspect of it, there are a lot of questions that, the first set of questions that come are around risk and regulation. So how do you embed that risk aspect into your design process in your organization? That's what
with multiple devices coming together.
Overall, in the integrated healthcare design.
Yeah, we're working on some pieces at the moment in North America around clinical operation centers. So you have IDNs, large delivery networks for hospitals. It could be a hospital system of 25 to 40 hospitals. And they have fleets of imaging equipment, patient monitoring equipment, other equipment, of course. Now, if we can start to pull data from all of those devices, including the health of that data, the health of those devices, sorry, then we can help them manage that fleet more effectively. And equally, as we're pulling data out of those devices, we can start to understand and predict what the demand is going to be on a radiology department or on a surgery or on staff as well. So by collecting data together, we can start to build dashboards and start to look at the utilization rates, but then using AI, start to run predictive algorithms that will anticipate when the demand's going to come and start to do modeling around in a stress condition, maybe it's an emergency situation in an ED, a disaster situation, what is the likely need that they've got, and then start to do modeling around that as well. And that's some of the work we're actually doing right now with some of the larger IDNs in North America. I think as we mature that technology, then it would again be good to look at how that could be applied here through the PIC, the Philips Innovation Campus in Bangalore, to the local delivery networks that we have across India as well.
Hello? Hi. Sorry.
There you are.
Hi. A design question.
Oh, good.
Users do not always know what they want. Is user research overrated?
So, users can't often articulate what they want or what they need. That's up to us to find ways of unlocking that. Now, there are a number of ways. Some of it can be derived from data, like we did with the baby bottle, like we're doing in imaging departments and emergency departments, where it's data-driven design. And that's a whole new skill set the design profession now has to learn, is how to interpret data and use it to predict and to anticipate a desired need. The other part of it is just having a dialogue with a user, they're not going to tell you the answer. You have to derive that. You have to pull that out. And that's where the contextual interviews, the design thinking practice, has many of the tools that are required to help people articulate their unarticulated needs and their latent needs. But in the end, you'll only get probably 80% of the way with the data, with the insights. There's still going to be, and this is me as a designer speaking now, that gut feel, the designer's intuition. What I'm happy to say is now that that intuition can be backed by data, and it's more informed than it's ever been. But still, I think we have to leave space for the little bit of magic, the little bit of creativity, and the little bit of beauty that can come from a designer understanding the human attributes of the problem, and not only the technical or clinical attributes of the problem. So beauty, science, creativity, a lot of things coming together here.
Thank you so much, Sean.